Sir, please start.
Good evening. As a MahaHappy convener and today's program coordinator, I welcome all to the MahaHappy platform. Dear friends, every year on 19th of June, it is celebrated as a World Sickle Cell Awareness Day to raise the awareness about sickle cell disease. And this year, the theme of the awareness is Global Action, Local Impact, Empowering Communities for Effective Self-Advocacy. And why there is importance of the awareness? Friends, raising awareness about sickle cell disease is crucial for promoting early detection, prevention, and proper management. So that's why we have to educate our healthcare professionals and general public so we can improve the health outcomes and reduce the disease impact. Everybody know the Indian government has launched Mission Sickle Cell Eradication Program to be eradicated by 2047. And the mission is to cover more than 7 crore people through screening and counseling. And the government is targeting more than 17 states which have high prevalence rates. That will suggest the commitment of the government to address this issue. So Team MahaHappy Academic Platform welcomes all esteemed faculties, CIP office bearers, MahaHappy office bearers, and volunteer members for today's special CME on sickle cell awareness. Friends, today we have galaxy of speakers across India who will be discussing basic form sickle cell disease and what is the advanced treatment in sickle cell anemia. Unfortunately, today's chief guest, Dr. Nivati Rathore, is not able to join as he has collector emergency meeting. To begin session, I will request our dear President, Dr. Sanjay Papane sir, to give his welcome speech.
And Namaskar. Good evening. As Sanjay has rightly said, the 19th June is celebrated as the World Sickle Cell Day. And we know the lot of work has been done at the government level, at the private level, and we are in the position we are talking of the eradication of sickle cell disease by 2047. Now, today's speakers, like our Madam Dipti Jain, we have seen her work in sickle cell disease since we were students when we were doing our post-graduations. And we have seen the extensive work of Madam. Till date, Madam is doing the great work in the sickle cell disease. I would like to welcome today's galaxy of speakers, Dr. Dipti Jain Madam, teacher of mine and teacher of most of us all, Dr. S.P. Yadav sir, and Dr. Chandak from Sambhajinagar for the different topics on the sickle cell disease. I also welcome all the office bearers of MahaHappy, Secretary, our dynamic secretary, Dr. Amol Pawar, convener, Dr. Sanjay Deshmukh, Vice President, Dr. Pankaj Agrawal, our editor, Dr. Rishi Lodia, and all the CIP and our treasurer, MahaHappy treasurer, Dr. Ravindra Sonone. Friends, yesterday only we had one topic. Today we are going for the academic particular platform on this World Sickle Cell Day. Tomorrow again there is a program. All this work, extensive work has been done. Our scientific chairperson, Dr. Minhaj Sheikh sir. I welcome all the OB-EBs of Maharashtra AP as well as the CIP-EBs and all the attendees who have joined for the particular program. Hope we'll get more enlightened about what we are heading towards and what work has been done and what work needs to be done in the future from our galaxy of speakers. So once again, I hand over the mic to Dr. Sanjay Deshmukh.
Thank you, Dr. Papane sir. Now it's our turn to our dynamic Dr. Amol Pawar to give his wishes on this day.
Thank you, sir. First of all, I welcome all the galaxy of experts, Dr. Dipti Jain ma'am, teacher of teachers, and Dr. S.P. Yadav sir from Medanta, Gurgaon, and Dr. Shraddha Chandak ma'am from Sambhajinagar, all the experts in hemato-oncology. And already President sir has told, Sanjay sir has told about 19th June and the World Sickle Cell Day, and it is celebrated across the world to raise the awareness about this sickle cell disease. So already many of the delegates have joined, almost 62 in number without MMC point, and friends across other part of states, Dr. Harpreet sir, Dr. Ashwini Agrawal sir, then Dr. Nitin Shah sir, President of Presidents, Dr. Nitin Shah sir has also just joined. So without wasting time, I will hand over to Dr. Sanjay Deshmukh sir and wish you all happy learning. Thank you.
Thank you, Dr. Amol Pawar.
Can I request Dr. Nitin Shah sir to comment
Yes,
as a
yes,
chief
yes.
guest
It's
now?
privilege. Yes, yes. Nitin sir.
Please, sir. Please.
No, so I think let's carry on with the speakers. If there are any comments, I'll make them at the end. No issues.
Sir, welcome.
Very good galaxy. Our Dr. Satya is there. He's like master of hematology, oncology, and stem cell transplant. And I'm sure he will also teach us which sickle to undergo stem cell transplant, because there's something which we don't use often in our country. There are some who are very severe in spite of giving the best of drug like hydroxyurea. They have a lot of issues, blood transfusion requirement, or strokes, or some such things. And these are the patient probably better we transplant them early rather than having chronic morbidity and then subject them to transplant. So that's one thing. And of course, how best to use hydroxyurea and how to monitor, especially when we give them from pediatric to adult side. They have a lot of issues in spite of the best treatment like hypocystinuria, renal damage, and so on and so forth. So all these issues need to be discussed together, and I'm sure the faculty is really marvelous today. So I'm very eager to learn from them. Thank you.
Thank you. Thank you, Dr. Nitin Shah sir, for your blessings and joining. So without wasting time, it's time to introduce our Galaxy speakers who are today guiding us in the management of sickle cell. First, I will want to introduce the first speaker, Dr. Dipti Jain ma'am. Dr. Dipti Jain ma'am doesn't need any introduction. Madam has decades of experience in the sickle cell disease. Madam is former professor head department pediatric in Government Medical College Nagpur. And we are very happy and fortunate and privileged that Madam is a chairperson for the task force of towards elimination of sickle cell anemia in India by 2047, the initiative of Government of India. So we are very fortunate. Madam is a co-editor for the Lancet Hematology, and Madam is also advisor for the Global Network Sickle Cell Disease. Then our next Galaxy speaker is Dr. S.P. Yadav sir. Dr. S.P. Yadav sir is the director, pediatric hemato-oncologist from Medanta, Mid-City, Gurgaon. Sir has more than 100 publications, and his area of interest is pediatric leukemia, thalassemia, and bone marrow transplant. So we go to hear our second speaker. And the last but not the least, our own young dynamic hematologist, Dr. Shraddha Chandak. She is attached with the Super Specialty Hospital at Chhatrapati Sambhaji Nagar, and she is the president of Happy Kids Foundation NGO at Aurangabad. So without wasting time, let's begin the session. Today, Dr. Dipti Jain madam is taking the journey and current challenges in sickle cell disease in India. So over to Dr. Dipti Jain madam. Pallavi, just start madam's slides.
Good evening.
Yes, sir, sharing.
Thank you for the kind introduction and Team IIP for inviting me to deliver this talk. The topic given to me is challenges in sickle cell disease. And I'm speaking on the World Sickle Cell Day today, 2025. Next slide, please. It was in 1952 that the first case of sickle cell was observed by Lehman and Kutbush. and in a tribal area and then non-tribal area. Next slide. For about 2 to 3 decades, there was silence. And it was in late 90s, it was found that the haplotype in India is different. Unlike other African haplotype, Indian haplotype is Arab Indian or Asian haplotype. That is what we call it. Next slide. Now, Arab Indian, these are the different types of haplotypes. And when we look at Arab Indian, it is has high hemoglobin F compared to the other haplotypes and has uh, co-inheritance of alpha thalassemia largely. Um, and there are other non-genetic modifiers. We do not know many modifiers yet, and the non-genetic like environment and weather, other factors also play a role in phenotype. Next slide, please. The general understanding is and was till now that India was not on the global map, any global studies or global meetings, India was not well represented, saying India doesn't have much of sickle cell disease. And if it has, it is mild because of high hemoglobin F levels. However, today we have established, and there's no doubt, various studies from various parts of our country have shown that sickle cell disease, in spite of high hemoglobin F, is not mild. Next slide, please. So, what is different about sickle cell disease in India? What are the few differences between sickle cell in India and other places? If we look at the genotype, around 80 to 94%, depending on the region, sickle cell disease is a very heterogeneous disease and it is not simple. It would vary from 80 to 94%, and sickle beta thal would vary from 6 to 20%. Rarely we get SD and SC also, but SC is the rarest, which is other way in African haplotypes, where they find SS in 80% and SC. SC is more there, like sickle thal here. So these are the few differences when we look at genotype from rest of the globe. Looking at the phenotype, what we get, and this might change from region to region. And below 18 years, we have stroke around 11%. We have cholelithiasis, hepatopathy. Portal hypertension is quite common, not much described in the literature. 29% of our patients have portal hypertension. Splenomegaly persists in second decade. The general understanding that we have spleen regressed by 7 to 8 years. Autosplenectomy, what we call, is not seen in around 80 to 82% of our patients, and we quite common see hypersplenism. Epistaxis is another symptom which we quite commonly see, not described in the book. And of course, avian and malaria and nutritional deficiencies, which are very unique to the developing countries. Next slide, please. Now, this is just to tell that there are acute and chronic complications, and each and every organ in the body is involved. Next slide. And the challenge is in identifying this organ damage early. As the lifespan of the patients, children of sickle cell has increased, we are seeing more and more organ involvement. So our challenge, our job is to detect organ damage as early as possible by doing anticipatory screening, like looking for urine microalbumin in kidney. We see right from age 5, while in the books it is mentioned start from 10. We do see at very early age. So in that way, it is very important today to screen for organ damage right from the early age. Next slide, please. Next slide. the crises are very acute, and one has to understand the subject. You have to treat patients with sickle cell disease to identify sequestration crisis, uh, a plastic crisis, and I think one learns from patients and has to be most of the life say death are due to this acute complications, and one has to be aware about these complications. Next, please. Next slide. Now, today I'm giving this talk from a small village in Madhya Pradesh, Anuppur. That is the village where I am. And here they have screened 3 lakh population in last 15 days. Imagine 3 lakh. And they have found 428 SS patients. I'm showing this slide today, which I'm here there. And the slide photo on the upper zone is of a patient where the mother and 3 children, all are SS. The girl sitting on the chair had stroke at the age of 4 years. The son has hepatopathy, and this child has frequent VOC. At the other end, this lady at in the pink sari is 43 years old, and it was only through this screening, she's a mother of 4 children. Only through this screening, she's come to know that she's SS. So, just to show that how heterogeneous the disease is. Next, please. Next slide. Now, coming to the diagnostic challenges, which are really many, and we are all aware that the screening test, though solubility not used or accepted in many parts of the world, we do have solubility even in our mission sickle project, because we may not have point of care test available as screening everywhere. Point of care test again has its own advantages, and also the interpretation. There are, I think, 24 or more point of care tests which are validated in by ICMR and are available for public use. And one thing more we are missing with the point of care which we have today is none of the tests validated in India are used for newborn screening. There are other tests which are used for newborn screening, but they are not made in India. And the mission uses tests which are made in India. However, of course, there are tests which are on the way where we'll be able to use in newborn also. Also, we are missing sickle thal. These tests, the screening test does not pick up sickle thal, which I think my area has 14 to 18% of patients are sickle thal. So that's a challenge. Of course, confirmatory test is HPLC, whatever CA, and of course PCR. But for us, it is HPLC. But the most challenging thing is newborn screening, and more than that, with the mission saying eliminate sickle cell by 2047. That means for me is prevent birth of a child with SS. That is my understanding of that mission. And that only by telling carriers don't marry carrier does not work. I've used that for 3 decades and it is very difficult. It is only through prenatal diagnosis that we will be able to control birth of SS child. And today I feel the weakest thing we have facility wise in the mission, even today, is the prenatal diagnosis facility, even the awareness. I don't think any child of SS should be born with this mission there and even with the facilities. Not only that, let me tell you, there was a group of parents standing outside once when I visited a center, and I thought they've come to meet me. One mother just shouted and said, "Why was my son born with SS?" And when such facilities of prenatal are available, Why was my, I said, how old is your child? She said 20 years. So I said, so these facilities were not available in those days. So that is how this era has come when patients are going to question us. And I think prenatal diagnosis is the most important thing, but is a challenge because the infrastructure is not there. And I would like to request our chief guest today that we must have a prenatal diagnosis facility in Nagpur. We should not be sending samples to elsewhere. Next slide, please. Next slide. Next would be regarding the newborn screening. The next slide. The newborn screening program, what we have seen everywhere in India is uh, the feasibility of doing newborn screening. Next slide of newborn screening. However, the most challenging thing for newborn screening is the follow up and enrolling these patients into a comprehensive health care and educating them also how to disclose the diagnosis of sickle cell to about a newborn to the parents is also a thing which we need to think about. Next slide. Yeah, this is the newborn screening was done in India. This was in GMC Nagpur, and this is the care we gave, and it was with Professor Sargent in 2002. Next slide, please. Next slide. Now, there is a study which has been done by ICMR in 8 centers in tribal areas, in 8 tribal areas in India, and we have found again the incidence varies from region to region, the severity varies from region to region, and this study has also uh, taught us what are the barriers and how to overcome them, apart from other things. So, this is the state in India today about newborn screening. Next slide. And it is very important to convince obstetricians and pediatricians to do newborn screening for sickle cell disease because by early intervention, in early care, we can definitely improve the lifespan and also the quality. Dr. Yadav is going to talk about the advances in management. Here, these are the treatment available today. Here, I would just like to put 2 sentences. Use blood transfusions when needed, not for any fever or any VOC. It does more harm than good. Next, don't give IV fluids, which we have given. I have given before. So don't give IV fluids to patients who comes with pain, with fever, without any dehydration or shock. It again precipitates acute chest syndrome. Hydroxyurea, the biggest challenge about hydroxyurea is we are not aware that tablets and syrup are available. They are cheap in India, so that is why we are giving capsules alternate day or twice a week or something. So that is the biggest challenge. The right dose and the compliance of hydroxyurea is not proper because of the thought that there only capsules are available. Small dose hydroxyurea is now very much available. Next slide, please. And it is cheap. Next slide. Now, this we know, and these are the challenges for hydroxyurea. And unfortunately, another challenge we have is around 25% of my patients do not respond to highest dose of hydroxyurea, that is accelerated dose of hydroxyurea. And we do not have drugs, 3 drugs which we were FDA approved. Only one remains. Voxelotor, crizanlizumab have been withdrawn from the market. And we have only L-glutamine today. And that molecule also is not available for sickle cell disease in India. I am giving are sachets which we use for malnourished children. Next slide, please. Next slide. Yeah, transfusion, again, I just wanted to tell that we do not have to give unnecessary transfusions, and ferritin is usually not a problem. Only 10% of my patients require transfusion. Next slide. Of course, there are definite indications when I have to give, but not all cases. It is life saving also in sequestration, in stroke. Next slide, in acute chest syndrome, but one has to. Just to tell, I think there are some medical officers here. What will we do when there is anemia? You say, don't give, madam, don't give blood transfusion. Most of the time, only these three conditions are the one where you really need transfusion. Splenic sequestration, hypersplenism, yes. Hepatic sequestration, you need transfusion. But rest of the things you can diagnose only by CBC. You do not need, and reticulocyte count, very important. Most of the time, it is nutritional anemia, and correcting that, you have better hemoglobin. Next slide. Malaria, again, for medical officers, I've seen patients sending to our hospital saying malaria is not seen in sickle cell disease. That is not so in India. In India and Africa, malaria is as common as in normal, normal person. Next slide. In fact, the mortality is high. I think this we always tend to forget. At least I never thought this as a problem till I was the chairman of the mission. I was told to prepare guidelines, and the first thing I started making guidelines for clinical management. I got a phone call from the secretary, tribal health, madam, start with the awareness modules, not with the clinical. Then I understood when I went into the detail how important it is to make an awareness and a counseling module, and the words you use and how you do. Social stigma is the big, everybody knows about treatment and other things. But I think how we create social stigma in the patient is a very big challenge, and one need to know about it. We gave color coded card in one of my projects, pink and blue, and I always used to show off color coding will tell ASAN. But now that has become a stigma, and the patient will say, no, we don't want to do blood testing. Everybody will know that what card I am having and I am SS. So I think we have to take care of stigma very seriously. It's a sensitive issue. Next slide, please. Next slide. I think here I want to tell that one has to remember it's a challenge because many patients come to us for disability certificate. Sickle cell trait, they are trait. They say we are sicklers. One lady called from Calcutta said, I want to go for bone marrow transplant. I said, why? She said, I'm pregnant and my sickle cell test has come positive. What sickle cell test? She said, I'm a sickle cell trait. So I think there are many myths about sickle cell trait, and one has to remember that except few, like they are more prone for renal complications and little about stroke. Sickle cell trait are normal. They do not need a disability certificate or any treatment. Next slide, please. Under special circumstances, of course they do. Next slide. Now, what is the role of government of India in this sickle cell? We must know that they have extended the newborn, under newborn screening, they've said that we should do screening within the first 90 days or the first contact of healthcare system. So it can be an immunization visit. So that is also they have taken. I will put it as early diagnosis. They have put it as newborn neonatal screening. Next slide. We are all aware about the portal which government of India has. It does not only tell how many are screened today, but also those who were, this is added recently, those who were diagnosed SS, were they enrolled in the comprehensive health program? Are they receiving hydroxyurea? What is the stock of hydroxyurea at the district hospital? So all this. One of the biggest challenge we had all these days were the guidelines. India did not have its own guidelines, and we were giving treatment as we thought of. Now we have very specific guidelines for clinicians, for teachers. awareness guidelines for teachers, for nurses, for health workers. So there are 12 guidelines available online, so we can use it. And this is the card where they say the status. And this is also used for counseling. I'm not going to explain how, but this is an innovative method which India has. We can predict the risk of a birth. What will it be? What is the risk of the birth having SS child? Next slide. Next slide. What is one challenge is integrating the screening, the mission program into the existing primary health program. That has to be done. Otherwise, this will not last long. And it has been done and it is going on well. Next slide. Next slide. Now we are, the challenges keep on changing. Now we have curative therapies. I'm not going to talk about curative therapies, but now the challenge is which are the whom and when should we send a child or a patient of sickle cell disease for curative therapies. Now that is one of the challenges, and Dr. Yadav will definitely talk about it. Next slide. Next slide. Now, this is my journey. And I think of these all with screening and newborn screening, hydroxyurea, compress, everything is being done except prenatal diagnosis is still at a very neonatal stage. Next slide, please. Next slide. So not to be very happy that so much has been done, but still, I think we are still lacking in patient education. The stigma, I would like to stress the counseling, also the medical care providers education. It needs, because there are areas where they've not seen sickle, and now sickle is seen everywhere. Patients are traveling and getting job elsewhere, studying elsewhere. One need to individualize the dose of hydroxyurea. I think that is what is very important today. And I already said curative therapy, to whom and when. Next slide. To summarize, I would say the unmet medical needs are we need a new drug apart from sickle cell disease, and maybe there is going to be an era of combination of drugs. One drug may not be enough. Different drugs acting at different level may be there. We need to we have already done most of the work extrapolating and applying concept of other haplotypes. We have made guidelines for our country, and what we have got new findings must be validated first. Even the point of care test must be validated. The hydroxyurea solution, which has been made for 600 rupees for 100 ml. I think these things must be validated in our country because of that. Next slide. This is my last slide. Here I just want to tell you that one of the challenges which I thought that somehow the juniors are not wanting to work in the field of sickle cell disease. But now with the gene therapy, and now this is an international conference on sickle cell disease in October in Chandrapur, and I see so many young students, doctors, and paramedicals are working so much on new concepts of sickle cell disease. I think that was a challenge, and they are becoming interested in this field. Thank you. I'll be happy to answer questions.
संजय भाऊ अनम्यूट करा, अनम्यूट संजय भाऊ.
Thank you, Dr. Dipti Jain, ma'am. It was eye-opening for us to learn what we are lagging behind to achieve the mission sickle eradication by 2047. And as you are a chairperson for this committee, we are very happy that this mission will be accomplished with the together effects of basic things, screening. So thank you very much, madam. I will request Dr. Nitin Shah, sir, to have his comments.
No, I think it's a wonderful disposition, and how much work can actually go at the peripheral level. I mean, kudos to madam. She almost sort of devoted her life toward the care of sickle cell. And I'm sure when the screening starts as a compulsory screening, And just for the information, the Mumbai Municipal Corporation had tied up with a private lab, and they were doing 7 screening, of which one. So it can be done. Of course, it was as a pilot, and I'm sure Goa is already doing it and some other states. But in our private practice, I think, I mean, mothers spend lakhs of rupees in private hospitals for delivery. The least they can do is an electrophoresis. Not only thalassemia minor, even I mean, not only sickle cell trait, even thalassemia minor will be picked up much easier. So, especially if you have a high risk community or a high risk CBC, which is done in the mother, these subjects should be at least subjected to electrophoresis, if not all the mothers who deliver. Today, it's a norm. At least the private hospital should do electrophoresis for every mother who comes for delivery, because you will be surprised sometimes you pick up a thal trait or a sickle trait or a E trait without their knowledge.
Thank you. Thank you,
Thank
sir.
you, Dr. Nitin, for endorsing that very important point.
Thank you.
Madam, I have only one question for you before winding up the question answer session. As you are the part of policy making, when is the ability of the suspension hydroxyurea in government setups in Maharashtra?
Okay. It is available online, but I think we are doing, there is a study which is in the analysis phase, and DG just, ICMR, we just had a meeting last week. We are looking at the cost of syrup against, there are tablets of 200 milligram against the capsule. And we have to convince the government that syrup is cost effective than the capsule. And it will be soon, I think within 6 to 8 months, it should be there, either tablet or syrup in the government setup.
So just to intervene, Dr. Sanjay, I know some people, of course, where I practice in Bombay, there is very little sickle. Of course, we do see it in the tribals and the high risk population, especially in the public health. Where I was in Wadia, we used to have a lot of sickle. But in general, in private practice, that's not that common. But I know people who treat sickle cell disease left, right, and center in Chhattisgarh, because as you know, sickle trait carrier rate is as 8% in Chhattisgarh. And I have some of my friends who are treating sickle cell patient there, and they vouch that they actually dissolve this capsule, not too many of them, in 10 ml of water, and store the remaining. They don't throw away, and use it on the second and third day. And they vouch that it works as good as if you were to give only the capsule. So I think the stability of even a capsule dissolve for a few days is good enough. I mean, so if patient is not able to take the capsule in its raw form, this is the least you can do till the time you have a commercial syrup available.
Yes, sir. Yes, sir. So thank you. Thank you very much, Nitin sir and Dipti Jain madam. Now we'll move on to, we are discussing the prevention and difficulties in Indian scenario, but what is the future? So today we have none other than Dr. Satya Prakash Yadav, sir. He's speaking on emergency therapies for the sickle cell disease. Over to you, Satya, sir.
Thank you, Dr. Sanjay, for the kind introduction, and thank you for the kind invitation to be part of this World Sickle Cell Day celebrations and awareness campaign. And this webinar is playing a very important role, because all the people who are listening to this webinar hopefully will find it useful in their practice. What Doyen of Sickle Cell, Dr. Dipti Jain, has just given a beautiful talk and updated us on the barriers, hurdles, and how we have overcome them, and future is bright. Like, we are working towards making sickle more and more curable in India, and prevention is going in a big way. Government's program, where I think nearly 90 lakh people are being screened every day in India, which is like a massive number. So I think once we have the full database, a lot of preventive strategies would be in place, and we can do much more for our patients. So the topic given to me is emerging therapies for sickle cell disease, and I have nothing to disclose. But we will start with just this first slide, which always is super impressive whenever I show in my presentation, that out of the 5 top congenital birth defects in children, third number is hemoglobin defects. So the first is congenital heart disease, where like 113 million children are born every year globally. And then neural tube defects, which are 3.5 million, sorry. and hemoglobin disorders 3.3 million. So it's hemoglobin disorder is a huge burden globally, and same is in India also. And it takes a lot of like economic burden and morbidity, mortality, and everything. So the burden is huge, and need for cure is a huge demand. That's very, very important. So sickle cell disease, which we're discussing today, it's a disorder of beta globin gene, and it leads to sickling crisis and leads to high morbidity. Patients suffer lifelong pain and recurrent hospital visits, and then early death or stroke or other things can happen. And transfusions may be required. So it is a huge burden on hospitals, on the health system. And globally, 300,000 children are born with sickle cell disease. And India is one of the few top countries, other after Nigeria, where maximum number of sickle cell patients are there globally. So the burden is huge. Now, what we can do for it and how we can manage these patients, as Madam has highlighted, that current era in 2025, hydroxyurea is the cornerstone of the treatment, that all patients should be given hydroxyurea. And as syrup is also going to be available soon, that would make small children, the drug would be available for them. And that's a very good news for India and for our patients. Other is red blood cell exchange and transfusion for severe sickle cell disease who have had stroke or likely to have stroke. So those patients sometimes are or very severe crisis that red blood cell exchange is required, and regular transfusion, certain subset of patients may need that. So that's important. Then curative options are bone marrow transplant, which I'm going to talk about in my talk. And gene therapy and gene editing is something new, which has just come up, just been approved in US recently, last year only. So bone marrow transplant, as you all know, that for bone marrow transplant, you have a patient who needs a transplant, and you need a donor whose bone marrow is fully matching. So there is something known as HLA typing, human leukocyte antigen typing, HLA typing of the patient and of the donor, usually siblings. And if your brother or sister is fully matched donor, then we can offer bone marrow transplant to cure sickle cell disease permanently. And how this bone marrow is taken out, this is how it's done in operation theater. That's me harvesting bone marrow. So the donor is taken to the operation theater and is given a general anesthesia, put in the prone position, and from posterior superior iliac crest, we can put a bone marrow needle and harvest the bone marrow about 5 to 10 cc per time, and in multiple directions from the same hole we can go. And the procedure takes about 1 to 2 hours, depending on the weight of the recipient, and two people do it simultaneously. So I am doing the harvest, and on the other side is one of my fellows, Dr. Neeta Radhakrishnan. She is doing it. So that's how it's done. So it's not something to be scared of. A lot of people think it's very complicated procedure, and God knows what all is done. So we just take out the bone marrow, and then it's given like a blood transfusion to the patient. And after 15 to 20 days, the new bone marrow starts working and starts making a sickle-free blood, and you're cured. But the first part, before putting in the bone marrow, we have to give chemotherapy to finish the old bone marrow. So 1 week of chemotherapy is required to finish the old bone marrow, and then we put the new bone marrow, and it takes 3 weeks for it to grow, and then you start making new blood. So that's how transplant is done. Then peripheral blood stem cell transplant is what is being done more commonly these days. So what is peripheral blood stem cell transplant? In this, instead of taking out bone marrow from the donor in operation theater, we take the donor to the blood bank and we connect him to an apheresis machine. But before that, for 4 days, we give GCSF injection, granulocyte colony stimulating factor, GCSF injections, which stimulate the bone marrow to make extra bone marrow, and the stem cells, bone marrow stem cells, come in circulation. Then we connect the patient to the donor to the apheresis machine. The blood goes into the machine from one side, from other side it comes back, and we collect the bone marrow stem cells in a bag, and then it can be given to the patient like a blood transfusion. So if we are taking out the bone marrow cells from the blood, then it is peripheral blood stem cell transplant. So this is also being done in a lot of centers, that instead of bone marrow, we do peripheral blood stem cell. Now, what is the commonest type of transplant we offer to sickle cell patient? It is matched sibling donor bone marrow transplant. Because in a family, if you have 2 or 3 children and you do HLA typing, then there is a good chance, nearly 30% chance, that your brother or sister will be a fully matched donor. But nowadays, families are becoming smaller. So 1 child or 2 child, so the chances of finding a donor are reducing. But in case you are lucky, the data is very exciting. So from the European Blood Bone Marrow Transplant and CIBMTR USA, they analyzed all the data from 1986 to 2013 and saw the outcomes of matched sibling donor transplants. Here, the median age was 9 years. And what they found was overall survival was 93% and event-free survival was 91%. So that's fantastic outcomes for a full donor, fully matched donor. And when they looked the data as per the age, they found the younger patients did much better. So if the patient was less than 16 years of age, overall survival was 95% and event-free survival was also 93%. But if you're more than 16 years, then your survival, overall survival dropped to 81% from 95%. So younger or earlier age of transplant before their organs are damaged or end organ damage happens has better outcomes, especially if you have a full match donor available. So refer early if you think your patient needs a transplant. Now, who needs a transplant? Dr. Nitin Shah, in his comments, had highlighted that we should all know in our practice which patients we should refer for bone marrow transplant. So in terms of, one is severity of the disease. So if a patient has had a stroke, even if it's a silent stroke, patient doesn't have any deficit, but it's a silent stroke, then that patient is a candidate for bone marrow transplant. If your cerebrovascular accident is likely to happen, you do transcranial Doppler, and the velocity is increased, you feel that this patient is likely to have a stroke, then those are also good candidates for transplant. Then, if you have a recurrent chest crisis or recurrent veno-occlusive crisis, bone pains, despite being on hydroxyurea full dose for more than 6 months to 1 year, and at least 2 to 3 episodes per year are happening, then those patients, if they have a full match donor available, should be strongly recommended for bone marrow transplant. So the severity of disease matters and the availability of full match donor, a sibling, these two things should encourage you to refer the patient for transplant, because results are exceedingly well. 95% cure rate is fantastic for a bone marrow transplant. Now coming to when you don't have a matched sibling donor, you don't have a brother, sister, like it's only 1 child, or you're unlucky, the next sibling is not a full match. Then what to do? And the child needs a transplant. So in this case, we look for matched unrelated donor transplant through the registries. There are a lot of registries globally which have more than 5 million donors who wants to donate their bone marrow. In India also, we have Datri registry where more than 2 lakh people are registered to donate bone marrow. But the chances of finding a full matched unrelated donor outside your family are almost nil for sickle cell patients, because sickle is mostly seen in tribal areas. The incidence of sickle cell disease is 1 in 10, like 10% in the tribal areas. And tribal donors are not there in the registries. Unfortunately, people from tribal areas are not registered in the bone marrow donor registries. So the chances of finding a donor are almost zero. So what to do? So alternate donor transplants is something which have been developed and that I will discuss in the coming slides. So one of the options which has been explored is half-matched bone marrow transplant, where mother and father are always half-matched to their child and their child is half-matched to the parents. So, and siblings also can be half-matched quite a number of times, and your first cousin, second cousin, your mama, chacha, tai, aunts and aunties can also be half-matched donors. So HLA typing, someone will be in the family who's at least half-matched and can be a donor. So first, I will describe the results of unrelated donor transplant. So in US, they did a trial, a BMT CTN trial, where they performed matched unrelated donor transplants for sickle cell disease patients. And out of these 30 patients, what they found was that survival was just about 76% at 1 year, event-free survival, and at 2 years it was 69%. And overall survival was about 86%. So at least 10% inferior to the survival which was seen in matched sibling donor when you have a brother or sister as a donor. And the other big problem was graft versus host disease. That means the donor cells caused a bad reaction, and that happened in nearly 30% of the patients. And chronic GVHD, the reaction of the donor cell continued for many years, and it was extensive in the skin, in the lungs, and other areas in nearly 38% of the patients. So you have replaced one chronic disease with another chronic disease. So sickle cell per se gives you bad quality of life. So you have cured sickle cell, but the chronic graft versus host disease is affecting your quality of life. So that was bad, and this trial was sort of negative. So since that, matched unrelated donor is not a preferred source of transplant at this point of time, although if you have a good match, it can be like a third or fourth last choice. Cord blood transplants were also attempted. I'll just summarize that cord blood transplants were not a success because of huge rejection rates. Nearly 50 to 60% of the patients rejected the unrelated cord blood cells. So there are cord blood banks, and if you have a cord which is matching, then some of them are offered transplant. But because of high failure rate, it has been now recommended that cord blood transplant should not be offered to sickle cell disease patients. Now coming to haploidentical transplant, which has a lot of discussions around globally. So this started way back in 2012, John Hopkins University, and John Hopkins people smartly developed a protocol in which whenever you want to do half-match transplant, you're not fully matched. You're likely to have severe graft versus host disease the donor cells will cause a bad reaction, and that can be fatal. So they said, okay, what we'll do the conventional chemotherapy will be given to finish the old bone marrow. And then we put in the new bone marrow from a half-matched donor. In the first 3 days, we will not give any immunosuppression. We will allow the donor immune system to fight with the patient. And anything which is proliferating very fast, dividing very fast, can be killed with chemotherapy, cyclophosphamide. So on the third and fourth day after transplant, they gave this chemotherapy, cyclophosphamide, and that killed the donor lymphocytes, which were going to attack the patient and cause graft versus host disease. And that took care of GVHD. And then half-match transplants were very much possible and with good success rate. So that's how they did impossible thing, which no one ever believed. And because it was so simple, it has happened globally. So Americans are in fact very angry. They have taught the world a simple technique of doing half-match transplant, and their value is reduced in the world. Now patients are not going to America to get the treatment. Previously, they were going there. So half-match transplants were attempted, and they did in the first 15 patients, 100% survival. Everyone tolerated the procedure well. No one died, which was very good. But rejections were high because the chemotherapy given was very less. They didn't want that someone should die of chemotherapy or toxicity. So it was a non-myeloablative transplant where they just suppress the immune system of the patient and put in the new bone marrow. Still 57% of patients were cured of sickle cell disease. This opened the gates for half-match transplants. Then came Apollo protocol. This is a work done in India from Gaurav Kharia in North India and Delhi. So what Gaurav did, that for half-match transplant, he developed a special protocol. Nearly 25 children were treated on this protocol, and he showed success of about 88% overall survival and event-free survival. And what he did was that when you're taking the bone marrow from the patient, instead of taking bone marrow, take peripheral blood stem cells and give them special injection called Plerixafor to the donor, which blocks the receptor where the stem cells attach in the bone marrow. So once you give this injection, all the bone marrow stem cells come out in circulation in big numbers, and you can collect them. So he collected big number of stem cells in the bag and then put it to the patient. And before putting it to the patient, he gave them pre-transplant immunosuppression. That means not just 1 week of chemotherapy, he gave them about nearly 6 weeks preparation before transplant, where he gave them low-dose chemotherapy, cyclophosphamide, fludarabine, and steroids. and that reduced the immunity of the patient so that patient doesn't reject the donor cells. And with this, he had zero rejection, no rejection, which is fantastic. And GVHD rates were 20% and chronic GVHD was 12%, which is very good. So this protocol has highlighted a good work from India for sickle cell disease patients that half-match transplants can be performed safely. Then came this paper in New England Journal of Medicine from US, in which they performed half-match transplant for sickle cell disease patients. This was BMT-CTN trial, in which nearly 54 patients were transplanted in 19 centers across US. The median age was 22 years. They were mostly adults, but the range was 15 years to 43 years. So they were adult patients in this trial. And here the overall survival was 88%, event-free survival again 88%. And the chemotherapy used was not very strong and again very well tolerated. This again showed that half-match transplants can be done for adult sickle cell disease patients with good success. So don't think that a 20-year-old or 25-year-old cannot have a transplant. If they're suffering, then please refer them for transplant because transplant can be done safely with a good success. Then this work from multi-centric trial, international collaborating effort, where nearly 10 countries came together and they did half-match transplant for sickle cell disease across the globe. Even our center at Medanta was part of this effort. And here again, nearly 78 patients had the transplant, and event-free survival and overall survival were in mid-80s, 85%, 84%. That was the survival, which was quite good. The only thing they found that the young children who were less than 13 years of age had slightly higher rejection rate, nearly 12% rejection. So they're working on it to reduce the risk of rejection, but it shows that it's quite safe and doable. So these studies have shown that half-match transplants can be offered to the patients who don't have a full-match transplant if they need a transplant. So first thing is that we should be very sure, does the patient need a transplant? Yes, if he has had a stroke, he has had repeated chest crisis or repeated bone pain, vasocclusive crisis, joint involvement, despite hydroxyurea, despite your best efforts, give him a year or so and see how your patient is doing. And if patient is suffering a lot, then ask them to meet a transplant doctor and they will guide them pros and cons of transplant, risks, benefits, and the success rate. And then patient can choose. But if you have a match sibling donor, don't even think, refer them. Because if you have a brother, sister, excellent outcomes. So this was all about transplant. Then what else can we do? Rest is gene therapy. So can gene therapy or gene editing cure sickle cell disease? Yes, it can. It is now FDA has approved two treatments. The gene therapy, Lyfgenia, is available in market, and gene editing called Casgevy, which is available in the market. So nowadays, gene therapy is being sold as a drug. So this is the era of cell therapy. You take out patients' bone marrow and you change their genetic makeup and then put it back into the patient. But a company is doing it. They're charging money to do all this. So these treatments are approved for only patients who are more than 12 years of age and have recurrent vaso-occlusive crisis because of sickle cell disease. Then only they're offered gene therapy. If they're less than 12 years, they're not offering gene therapy at this point of time. How it's done? You use a viral vector. So we take out patient's bone marrow, and with the help of a viral vector like adenovirus, lentivirus, we put the beta globin gene into that bone marrow and correct the sickle gene, replace it with a corrected beta globin gene, and then put these cells back after giving busulfan chemotherapy, and you are cured. The other is the gene editing. So how is gene editing different from gene therapy? So in gene editing, we don't use a virus vector. What we do is we can edit the genetic code of the patient's bone marrow cells. So how it's done? We all know that when the baby is in mother's womb, we make fetal hemoglobin HbF, which has alpha and gamma chains. And when we are about 6 months old, we start making HbA, adult hemoglobin, alpha and beta chains. So there is switching off of silencing of gamma chain and activation of beta chain. That's what happens in our genetic code. So the protein which switches off gamma chain is known as BCLA11 protein. And there is a gene, BCLA11 gene, which makes this protein which silences the gamma chain production. So now with gene editing, with CRISPR-Cas system, we we cut out the BCLA11 gene from the genetic code of the cells, and they no longer can block the gamma chain, silence it, and gamma chain production restarts, and patient starts making fetal hemoglobin. And then you're cured of your sickle cell disease. So this is available now as a treatment in US and in Europe. So is gene therapy safe for sickle cell patients? That's the question everyone asks. Okay, it's available, but is it safe? So far, the viral vector one, so the product which was made using a virus vector, it caused leukemia in about 3 patients after the treatment, and the drug was withdrawn. Lyfgenia was withdrawn in 2019 after initial approval because 3 patients got leukemia after gene therapy. But later on, they found that it was not because of gene therapy. The leukemia happened because of using busulfan chemotherapy prior to giving the gene corrected bone marrow. So they reopened and gave the approval again, and the drug is being now, since 2022, this gene therapy is being given, and so far nobody has developed leukemia. Gene editing has been tried in 78 sickle cell disease patients, and so far no one has developed any leukemia. So long-term follow-up is still required. 15 years follow-up. FDA recommends that any patient who gets any gene therapy should be monitored for 15 years. Then only we can say this product is very, very safe. So still jury is out. Maybe another 10 years, a decade is required before we can say the gene therapy is super safe. How costly is gene therapy? So if your patient wants gene therapy, Casgevy is product from Vertex company, and it's a gene edited product. It costs $2.2 million, so about 16 crore rupees. So quite expensive. It's available in US and Europe. Lyfgenia is a Bluebird Bio Company product, and it costs $2.8 million. So beyond Indians or people living in India to go and get gene therapy in US or Europe, very expensive. And is large scale production going to be a challenge? Can you manage like lakhs and lakhs of patients? India has like nearly like 30, 40 lakh patients of sickle cell disease. So can all of them be treated with gene therapy? Yes, scaling up is a problem. In US, Lyfgenia, Bluebird Bio Company has 27 centers approved, and they have capacity to do only 50 gene therapy in a year in entire US. So that capacity is very less. So there is a huge waiting list, 6 months, 1 year waiting. Casgevy, a Vertex company, has 9 centers approved in US, and they can also do just about 10, 12 patients in a year. So there is still scaling up is a problem of gene therapy, that you cannot do it on a large scale. So far, the capacity is lacking. What about India? In India, ICMR, CSIR are working together with AIMS Delhi to develop gene editing for sickle cell disease. A lot of lab work has happened. So CRISPR-Cas, Indian CRISPR-Cas has been developed, because CRISPR-Cas, if you buy from US, it's very expensive. They charge a lot of money. So we have developed our indigenous, Dr. Divyajyoti Chakrabarti has developed indigenous CRISPR-Cas system, and that would make it very, very cheap in India. And some work in mice model has started, and we are expecting a clinical trial to start maybe this end of this year or next year in AIMS for gene editing treatment for sickle cell disease. And it would cost in lakhs, not in crores. So maybe 20 lakh, 30 lakh, 40 lakh, something like that. Something similar to CAR T cell therapy, which is available for nearly 30 lakhs right now for leukemia and lymphoma patients. So this is all I had to tell. Thank you so much. And that's our team at Medanta, and that's my hospital. Thank you. I'm happy to take questions.
Thank you, Dr. Satya Prasad Yadav, sir. The future is, I hope in future in India, the people can afford what is the best available in the Western countries, that is gene therapy. It is too expensive at present. Even for the bone marrow transplant, we are getting difficulties to get a finance.
So I will make a comment regarding bone marrow transplant. So there is a scheme called Thalassemia Bal Seva Yojana from Government of India, where 10 lakh rupees are being given for thalassemia patients to have a matched sibling donor bone marrow transplant. So in this scheme, sickle cell disease is going to be included soon, maybe 6 months within this, by end of this year, it will happen. So sickle cell disease patients will also start getting 10 lakh rupees from government for bone marrow transplant if they can't afford. Thank you.
But that is for from the central India, sir, because in Maharashtra.
Yes. It's from government, central government, 10 lakh. And on top of that, they can take help from the local government like CM Relief Fund, PM Relief Fund, that is also allowed. So it will make very much possible. Like nearly 800 thalassemia patients have had free transplants across India with 95% success rate. So if it can happen for thalassemia, it can happen for sickle cell disease also. So I'm hoping, and this would be a very good move by Government of India to include sickle cell disease in Thalassemia Bal Seva Yojana. Thank you.
Yes, sir, rightly said. But unfortunately, in Maharashtra at present, we're hoping the Maharashtra government can initiate. I think they are in talk with the Sickle Foundation. They are providing the funding up to 12 lakh rupees. But Sickle is not included at present in Sickle Foundation. So they are trying to include that in the BMT program. So, Dr. Nitin Shah, sir, do you have any comments?
No, I just wanted to say that every thalassemic child born should actually undergo transplant. Today, we have good success rate even with haplo, and parents are always there. I mean, that's what China taught us, that if you have only one child as a policy, where is a sibling? So thalassemia, we must push them for early transplant. But sickle has its own indication, and fortunately, most of our sickles are not as bad. So sickle may not be that much issue treating as much as thalassemia. Thalassemia, you prolong transplant till a later age, then the success rate drops.
Very correct, sir. Thank you.
And other thing is, every thalassemia is a potential transplant recipient, so he must be chelated well and transfused well to keep his liver spleen size almost non-palpable, good hemoglobin, good growth, no organ damage, and good chelation to keep ferritin below 1000 as far as possible, so that Dr. Satya can then do an haploidentical whenever the parents are ready. And I'll tell you one thing, I have yet to see a child who needs transplant, but for money, he's not able to do it. That's never possible. There are several centers, like in Mumbai, we have Vadia, we have Sion Hospital, we have the Borivali Center. They are all there is a charge of 8 to 10 lakh, but so many donors are there that parents really actually contribute only few lakhs, if at all, and it is possible to do it. So unless leukemia, where it's an emergency because patient can't wait for too long, this chronic diseases, there is enough time to collect money, and there are good philanthropic donors who help come out and help us with the donations.
Rightly said, sir. Yadav sir, I have one question for you. If somebody want to donate the bone marrow, can you tell the process? If anybody can.
It's very simple. There is a registry called Datri registry. You can Google Datri, Datri, Datri. It's in Chennai. And you can register as a bone marrow donor with them, and they will take your they will do your HLA typing free of cost and put your report in a database, and anybody can search that database, any doctor. And if you are a match to the donor, you can donate. And you should be within, say, 18 to 50 years of age. If you are 50 years plus, then you're not eligible to be a matched unrelated donor. So you should be a healthy person and willing to donate and register yourself, and that's possible. Yeah.
And so what's your experience? I have heard once you register, there's a lot of rejection by the donors when the.
Yes, so that's a problem in India because a lot of donors are young donors working in corporate world, like in Bangalore, Hyderabad, these cities. A lot of Bangalore people have registered. But when the time comes to donate, their parents don't allow them to donate. So they said, oh, no, you will become weak if you donate bone marrow. And somehow they refuse. Last moment, young people like 25-year-old or 28-year-old, they have registered, they are fully matched donor, and dropouts are there. And that's a big problem in India with unrelated donor registries. So I think the parents have to be counseled. Anyone who is approved as a donor, they should have few sessions that in case you are a match, what will happen?
That, and I think the worst is that the donor agrees and undergoes all the testing, which will cost at least 30, 40, 50,000, and then says, no, I don't want to. But he has a right to reject till last date. And then, then the poor parents have actually lost that money and the hope both. So I think it is also donors' responsibility. They don't want to donate, they should reject right away when they are approached, rather than after undergoing all the tests for fitness and then to say, now I'm worried and I don't want to give.
So more counseling and it is needed when someone wants to donate bone marrow.
Absolutely.
That's needed. Yeah.
Thank you, Dr. Yadav sir.
Thank you.
Going to our last session, which will be delivered by Dr. Shraddha Chandak ma'am, and she is going to speak on best practices in sickle cell disease. So over to Dr. Shraddha ma'am.
Yeah, thank you, sir. Am I audible?
Yes, ma'am, you are audible.
Sir, please allow me to share my screen.
Yes, okay. Pallavi? Pallavi?
Sir, already permitted.
Okay.
Uh,
Yes, ma'am.
Already given
Yes.
permission, sir.
yeah, is it visible? Screen is visible?
Yes, ma'am. Make it full screen.
Yes, is it visible, sir?
Yes, ma'am, it's visible.
Okay. Yes.
Your screen is visible, but not you.
Okay. Sir, actually, I am in traveling. I am in a car. So there is a light issue. So I may not be visible properly.
Oh my.
Uh,
I hope you're
yeah.
not yourself.
Yes. No. I'm not driving. Driver is there, but I have stopped the car for my lecture at side place and I'm doing it. So good evening, everyone. So first of all, I would like to thank Team Maha IAP platform, all the seniors, my teachers for giving me this opportunity to present here my little bit of work and my talk. And first of all, before I start my lecture, I would like to acknowledge all my teachers, friends, colleagues, because of whom today I am here, and especially Dr. Dipti Jain ma'am and Nitin Shah sir, who are present here. Dipti ma'am is my mentor, my guide at GMC Nagpur. And frankly speaking, presence of you both making me little bit nervous, but I will try my best. So topic given to me is the best practices in sickle cell disease. Actually, there is no best practice as such whenever it comes to a medical practice, because every individual differ, and as we see the various presentation of sickle cell disease across the globe. Not two patients are similar in any way. So we have to individualize the management approach according to every patient. So the my talk is on the best practices in sickle cell disease. Frankly speaking, it is very difficult to cover in 15 minutes, but I have tried. So let's go ahead. So as we have seen in before two lectures that there are sickle cell affects all the systems of our body, and it's a condition. It's not a disease, I will say. It's a genetic condition which is present from birth till the end. Whatever problems we get, it is because of its complications, and that we known as a crisis. So we are managing the crisis, and to manage the condition, we have just seen the emerging therapies like gene therapy, gene editing, and transplant. So the best practices in sickle cell disease is the mainly proactive management, early intervention, and multidisciplinary approach. So it's a teamwork. It's not a case of individual work or only hematologist can manage everything. So to manage any sickle cell disease patient, we need pediatrician, hematologist, nursing care, proper genetic counseling, dentist or paramedical staff, primary care, hydroxyurea becoming the mainstay, psychological support, physiotherapy, ortho care, social worker for the socio-economic help, all these things. Now every team, all this team, they form a multidisciplinary approach for the comprehensive care in sickle cell disease that makes the best practice in the sickle cell disease. So the management includes prophylactic management, preventive management, and treatment of severe symptoms. So general principles of the management of sickle cell disease is to improve the quality of life, life expectancy of affected individuals, prevent and reduce the number of crises and complications, treat crises and complications promptly and effectively, and promote the healthy lifestyle. So basically, we are treating the complications, we are reducing the morbidity rather than at present aiming to the cure the disease. So the preventive care It starting with our vaccination, which is most important to prevent against the life-threatening infections. As we know, the sickle cell disease is like some immunodeficient condition because there is a hypospleenia, and therefore we need to vaccinate the child against pneumococcus, H influenza, meningococcal, which are compulsory for child with sickle cell disease. Prophylactic antibiotics, again same, that the child is with the functional hyposplenia, and therefore they are prone for the infections with the diplococci. So the pented prophylaxis or penicillin prophylaxis, which is recommended. So the doses are like below 1 year, it is 60 mg per twice a day. Up to 1 year, it is 125 mg twice a day till the 2 years of age. And after 2 years, they have said it should be given till 5 years, but ideally it should be continued till 18 years of the age, 250 mg per day. Then the comes is the folic acid supplementation. So why folic acid supplementation? Because sickle cell disease is a condition with increased red cell turnover, and therefore there is a folate deficiency state occurs, and that's why we are giving folic acid supplementation. The dosage are like below 1 year 2.5 mg OD, and after 1 year it is 5 mg OD. Good hydration, that is the mainstay of the preventive therapy. That whatever is the season, whatever is the timing of the day, the child of the sickle cell disease should be well hydrated, not underhydrated or not overhydrated. So the hydration will keep or will prevent the excess sickle polymerization and will help in preventing the crisis. Temperature regulation, same. Uh, we should ask our patients to avoid the extremes of the temperature, too cold or too hot. They should try to maintain the ambient temperature around them, so that will also prevent the sickling polymerization. Exercise safely, yes, we should ask them to do yoga, to do mild to moderate exercise, but not very strenuous exercise which will cause rapid dehydration and the crisis. Avoid smoking and excessive alcohol. So that comes under preventive. But what is early intervention and management? So early intervention is like before, like timely identification before anything or the damage sets in. So that needs a regular monitoring. So clinical checkup, health checkup, then regular labs at least once in a 3 months, like CBC, LFT, kidney function test, serum electrolytes, calcium, thyroid profile. Once in 5 years, at least a 2D echo, transcranial Doppler. So yearly, monthly, those lab monitoring is very important, because that will give the alarming sign that yes, something is going wrong and there we need to intervene. Hydroxyurea, as we have seen in earlier lectures, at present it is the mainstay of the management. Why? Because the hydroxyurea, it acts on the RBC as well as it has a vascular effect. So in vascular effects, it decreases the WBC platelets, decrease the endothelial activation and adhesion of platelets, decrease the thrombosis, microparticles, and decrease the risk of vasoconstriction. While hydroxyurea, it augments the HbF or increases the production of HbF by augmenting the gamma globulin gene. Then it decreases the HbS polymerization. So there is decreased RBC membrane damage, decreased hemolysis, and there will be indirect rise in hemoglobin. So it improves the tissue oxygenation and decrease the inflammation. So this is how the effect of hydroxyurea, that we see that the sickle red cells are less and the sickle the RBC maintain their normal shape. So dose of hydroxyurea, it is 10 to 15 mg per kg per day in a single daily dose. Then follow up with the CBC every 2 weeks, because hydroxyurea is known to cause agranulocytosis and the thrombocytopenia. Monitor serum biochemistries, LFTs and KFTs. If no major toxicity, we have to escalate the dose every 6 to 8 weeks until that maximum dose or desired endpoint is reached, and the hydroxyurea should be continued lifelong. Then other therapies, like as we have seen in earlier lectures, that there are along with the hydroxyurea, there are some molecules they have been discovered, invented for the management of sickle cell disease, but somehow nobody had hold that much of promise as hydroxyurea had done. Like voxelotor, which increases the hemoglobin affinity for oxygen, improves the RBC shapes, flexibility, and lifespan. Crisalinizumab, that is humanized monoclonal antibody, and that works by binding the P-selectin and therefore reduces the vaso-occlusive crisis. Similarly, L-glutamine, which decreases the RBC damage, keeps cells stay round, flexible, and less adherent to endothelium. Finally, all these molecules, they are working by decreasing the polymerization, decreasing the endothelial damage, and maintaining the RBC shape and size so that polymerization will be prevented. Then prasugrelin, which is an adenosine diphosphate receptor antagonist, and it reduces vaso-occlusive crisis by inhibiting platelet activation and aggregation. And the mitapivat, which activates pyruvate kinase in RBC, it increases ATP, decreases 2,3-DPG, increases the RBC health, survival, and oxygen affinity, and decreases the RBC polymerization. But as we have seen that there are no FDA approved these molecules, we have got crisalinizumab. Initially they had recommended, but then now it is not working and we are not giving it. And so at present we have the hydroxyurea, which is the promising drug. The most common manifestation of sickle cell is the pain management, and really telling you, we are making a crime, we are doing a crime if we underestimate the pain of a sickle cell child. So we can't ignore, we can't say that child is malingering. So whenever child comes with a pain, we have to first counsel the parents that don't ignore the complaint of pain in sickle cell disease. Whenever child complains of pain, please give attention, give the first dose of a painkiller, then scale the pain, give score from 0 to 10, and try to find out the reason for that pain, which we can take care of that. So general approach for the pain management, that managing pain with the oral medications at home. If this works, fine. If not, then please seek the medical attention at emergency department. We can give the IV NSAIDs or painkiller. If not, then IV opioids. If not, then admission to inpatient department for better pain control. If pain persists, then consider the alternative pain medications. And then also, if no improvement, then the consult the pain specialist. So pain is the main symptom of sickle cell disease. So pharmacological intervention, it is multimodal approach to provide quick and effective pain management at home, emergency, and inpatient admission. The mainstay is maintain the adequate hydration along with the pain management. And there are some non-pharmacological intervention which we can give to distract the child from during the painful episodes and prevent the complications, like heat pack, physical therapy, auditory relaxation, music therapy, cognitive therapy, biofeedback, acupuncture, sleep hygiene, and incentive spirometry use. Then when we are scaling the pain, if it is the mild pain, just trial of NSAIDs, paracetamol. If it works well, okay. If not, then we can go for the moderate pain, that is score 4 to 6 with oral morphine. Then if pain control, that is fine along with the paracetamol and NSAID. If not, then if it is a severe pain, then we can have only a daycare admission, or it is the proper admission for the pain management. Now that may need your continuous IV opioid infusion or on-demand dose, sometimes patient control analgesia or nurse control analgesia, that we have to take a call as long as the child is going through the pain. So the first point is that whenever child complains of pain, that pain should be addressed within the 1 hour of the onset. Role of transfusion, as we have seen, it is not, unlike thalassemia, it is not like every monthly or regular interval we have to transfuse the child with sickle cell disease. But why do we need transfusion at times? With transfusion, we improving the blood flow by reducing the proportion of sickle polymer, limiting the hemolysis, endothelial damage, increase the blood oxygen carrying capacity. So that's why in some scenarios that we will see that the transfusion is must or necessary. But what type of transfusion? Yes, we need a packed RBC, that is red blood cell transfusion. But is it only ABO and RH compatible is sufficient? Then I will say ki no, we need a extended red cell antigen profile which should be checked initially either by genotype or serology, because since this patient they need a repeated transfusions, multiple transfusions, so there will be the risk of alloimmunization will be decreased. And if there are any reactions, the antibody identification will be the easy, so that we can select the donors in this cases when we have a extended red cell antigen profile of each and every patient of sickle cell disease. So indications: in acute conditions like symptomatic anemia, if hemoglobin is very low, or severe anemia like less than 4, less than 5, sequestration crisis, acute chest syndrome, neurological syndromes, whenever there is a major surgery which is requiring general anesthesia, surgery is lasting for more than 1 hour, and we need to keep hemoglobin above 9, yes, we need to give pre-op transfusions. Acute multi-organ failure or sepsis. While in chronic transfusion therapy, we have certain specific indication in sickle cell disease like primary or secondary stroke prevention, pulmonary hypertension, recurrent sequestration crisis or chest syndrome, anemia associated with chronic renal failure, and congestive cardiac failure. So type of transfusions which we are giving said in sickle cell disease is like a simple transfusion as we are giving with the peripheral line, and it is the fewest red cell units are required, the exposure is very less. But again, disadvantage like hyperviscosity, circular overload, and iron overloading. Then there is a manual RCE, that is red cell exchange therapy. So that can be done peripherally, but generally it need a central line will be better. But the disadvantage, again, it needs more red cell units, so the exposure will be high, and it needs specific training. And the lastly is the automated red cell exchange transfusion that can be done peripherally, but again, it will need a central line, and the advantage, it minimizes the blood volume shifts to continuous removal and replacement, accurate control of HbS, hematocrit, and overall fluid balance, and lowest treatment frequency. But the disadvantage, it is quite expensive, it needs a specialized device, training, and specialized personnel, and the most red cell unit required, so the exposure to the red cell antigen is the highest with automated RCE. When we have seen the indication, then we must know that when not to transfuse, what are the inappropriate indications of transfusion. So whenever there is uncomplicated vaso-occlusive crisis, priapism, ARF without systemic failure, organ failure, asymptomatic acute anemia, leg ulcers, infections, minor surgery without GA, avascular necrosis, uncomplicated pregnancy, and TIS, they do not need transfusion on regular basis. So please be very meticulous, be very specific while transfusing sickle cell disease. The crisis management, the most important is like acute chest syndrome, which is the leading cause of death. It is the second most common cause of hospitalization in sickle cell disease. So whenever there is fever, respiratory symptoms, and if we can see any new infiltrates on chest X-ray, we should suspect acute chest syndrome. The main cause of acute chest syndrome are the multiple infections like bacterial, viral, any true thromboembolism, fat embolism, or atelectasis secondary to the pain due to rib and vertebral infarction and reduced respiratory drive and cough can lead to acute chest syndrome. Now, why it is very important? Because sickling occurs in lungs, impairs pulmonary microvasculature, causes worsening of pulmonary function, desaturation of systemic blood, which again enhances the hypoxia and erythrocyte sickling, and sickling again promotes more sickling in lungs, and this vicious cycle continues, and finally the patient succumbs. So the treatment, the first of all, whenever child comes with respiratory syndrome, always keep in mind the possibility of acute chest syndrome, monitor airway, breathing, circulation, give crystallite fluid very meticulously because we have to watch for pulmonary edema, maintain the saturation above 95%, antibiotics, incentive spirometry, patient control analgesia, pump narcotics, bronchodilators, and sometimes RBC transfusion or exchange transfusion is needed to treat the acute chest syndrome. The second most common crisis and the most important is stroke. So whenever there is drop in hemoglobin, WBCs are high, there is a history of prior TIA, there are any silent brain infarction, when patient is experiencing acute chest syndrome in last 2 weeks, whenever there is increased systolic blood pressure and there is high speed of blood flow on transcranial Doppler, these are all risk factors in this for this stroke in sickle cell anemia. So there are three conditions that we should know: that stroke, silent stroke, and TIA, that is transient ischemic attack. So stroke is frank stroke where we can see the neurological deficit clinically as well as radiologically. While silent cerebral infarction, that is lesion visible on MRI but no associated finding on clinically. While TIA, we have a transient episode of neurologic dysfunction, but there is no neuroimaging finding. So these three are the different things. So the main important thing is like a transcranial Doppler screening. And the guideline says that annual TCD should be performed for all children with homozygous sickle cell as well as sickle beta thalassemia. And whenever there is an abnormal TCD velocity, if it is like more than 160 or 50 to 160, then the blood transfusion therapy every 3 to 4 weeks is recommended. And the blood transfusion, at least we should give for 1 year with the goal of maintaining HbS below 30% and to maintain the hemoglobin levels above 9. So whenever there is an acute presentation of stroke in a sickle cell disease, then we first, if it is child is presenting within below 72 hours or within 72 hours, maintain the oxygen saturation and see the hemoglobin level. If it is less than 8.5, simple transfusion can work very well. But if it is more than 8.5, then child needs exchange transfusion to keep the HbS level below 15 to 20%. Then what we have recommendations that use transcranial Doppler screening in all sickle cell along with hydroxyurea for primary stroke prevention in our country, okay, where there is a socioeconomic status is very much affected. But in high resource setting, it is recommended to do surveillance for developmental delay, cognitive impairment, and neurodevelopmental disorder in children. Use of MRI imaging of the brain without sedation to detect silent cerebral infarct at least once in early school age and then once in adults with sickle homozygous and sickle beta thalassemia. The next, like when to seek, we need to give the best care in sickle cell disease. We need to give some guidelines to the patient as well as parent that when to seek medical help. So the red flag should be explained to each and every parent that if fever above 101 Fahrenheit, there is difficulty in breathing, chest pain, abdominal swelling, sudden problem with vision, severe headache, sudden weakness or loss of feeling or movement or speech, seizures, painful erection, and pain anywhere in body which is not responding to the medications at home, they should come to emergency department within 1 hour of these symptoms. That is most important. And why? Because we need to keep all sickle cell disease patients safer. So what is safer? This mnemonic start for the stop the pain. So appropriate level of narcotics are essential. Administer the appropriate amount of IV fluids. So no overhydration, no dehydration. Fever. If child with sickle cell disease is having fever, please do not ignore. Require immediate blood culture sample to get and give the first shot of IV antibiotics and treat the possible bacterial sepsis. Execute the guidelines for stroke, acute chest syndrome, or whatever the condition child has presented with, and reduce the morbidity associated with inadequate acute sickle cell care. So safer should be followed in each and every casualty where we come across the patients with sickle cell disease. The next comes that along with this all physical needs, that we have to give attention to the psychological health of the child. Now, basically, this problem comes when child is growing and they come to a adolescent phase. So they face adolescents, mainly they face psychological challenges because of chronic illness, multiple admissions, multiple painful episodes, every day taking that hydroxyurea and folic acids, and literally they get frustrated. So the psychological counseling and peer support groups may help with emotional and social adaptation. Educational support is very much required to manage school and extracurricular activities. And then we have to targeting the changes in institutional organization practices. We may need to form the patient group sessions. Family therapy is needed to work for a child. After that, finally, what was our initial goal when we were going through the slides, that to maintain the quality of life, like we have to give the good quality of life. So our aim should be that every child of the sickle cell disease, they should enjoy near normal life and lifestyle, experience full physical and emotional development from childhood to adulthood, participation in sports, educations, employment, marriage and reproductive life, nutrition, supportive care, and they should be free from any addictions. So that should be our main aim, to maintain the good quality of life. Transition to the adult care, yes, that once it is like we are taking care of our child, and once child has grown up, now we have to hand it over to adult hematologist. So we need to begin early preparation for transition to adult care, educating the patient about their condition, encouraging the self management, medication adherence, which is most important, understanding their medical needs, that when the identification, the early signs of developing crisis, and what precautions that they should be taking, that we need to tell them. The coordination with adult hematologic services, and then the clear communication between the healthcare providers, and the seamless transition between pediatric and adult healthcare services should be done. Then management of sickle cell disease in pregnancy. Now, pregnancy, any pregnancy in sickle cell disease is always a high risk pregnancy. And what are the risks that we come across? The risk of infection, risk of thromboembolism, preeclampsia, spontaneous miscarriage, preterm labor, antepartum hemorrhage, IUGR, maternal and perinatal mortality as compared to a normal population. So they need a complete health checkup, treatment of anemia, regular folic acid, calcium, vitamin D supplements like any other pregnancy. But the most important, we need to ask parents to stop hydroxyurea 3 months prior to a planned conception. No chelation medicine should be given during pregnancy because they can be teratogenic. And what is needed is, main important thing is antenatal genetic counseling of all parents is very important before their planned conception. Then finally, since technology is getting advanced, and we need to use those technologies in our healthcare. So the telecommunication, so it should not be limited to only our lectures and webinars, but teleconsultations we can use in the management of these chronic diseases. Why? Because it will improve the access to specialized care. It is like a teleconsultation is like bridging the gap between tertiary care and remote rural places. It will avoid unnecessary travels, decrease chances of missing follow-ups of the patients, and the chronic disease monitoring can be done virtually, like pain episodes, medication adherence, reviewing lab results, and telepsychiatric and counseling. So care coordination across hematologists, primary care, pharmacy, nutritional, and social worker is easily possible with teleconsultations. Patient education and self-management can be done. Now, as we have said, that it's not only a job of any private practitioners, any nursing home, but it is a nationwide program where in India lakhs of population is affected with sickle cell disease. So government of India has taken a very good initiative to give the best and best care to the child suffering from the sickle cell disease. But everything needs a team. So the team which gives the expanding services, continuous care, then there are finances are involved. It needs good infrastructures, IT systems, and everything. So we need to form a patient support system. So the ASHA worker, ANM, multipurpose workers, community volunteer, can form the group, and there is something known as Jan Arogya Samiti. Now, this Samiti that increases the awareness about sickle cell disease in community, then it helps to get the social, financial, nutritional support to the affected families. There is sustained availability. This ensure that there is a sustained availability of medicines and diagnostic for sickle cell disease, and there is a linkage with skill development programs and other relevant national programs. Then there is something known as a community adoption. So it is the more wider we go, and leveraging community support by identifying and orienting and motivating voluntary individuals and organizations. So they help to provide the additional support to improve the health outcomes in sickle cell disease, and leverage corporate social responsibility also. So it's not me, it's not you, or it's not any individual, but it's we that we can help the child with sickle cell disease to live optimally and optimistically, and to give best in their life. So with this, my take home message is only like in sickle cell disease, early identification of abnormal symptoms and sign is important. Promptly addressing the crisis and their management, growth monitoring, complete vaccination, hydroxyurea, folic acid supplementation, pentid prophylaxis, opting the healthy lifestyle, regular exercise, no addiction, and most importantly, it's continuous counseling, conversation, education, and support to the patient and family that will help us to offer a best care for sickle cell disease. With this, thank you so much for the patient listening. Thank you so much.
संजय भाऊ, अनम्यूट अनम्यूट. संजय रे, अनम्यूट.
Minaz is unmuted, but I think his bandwidth is not correct. That's why.
Minaz sir,
Yes, yes. Sir.
Minaz sir, over to you.
Okay, okay. I request Nitin Shah sir to make some comments on the presentation of Dr. Shraddha, please.
Oh, so I have quickly three things to say. Number one, hydroxyurea is the main drug. Should be started as early as possible, even in a very small charity safe. Number one. Number two, give the optimum dose. Need not give the maximum dose, just to keep the hemoglobin at around 9 and 10. Don't give to make hemoglobin 12, 13, because that will lead to more hemostasis because of the hyperviscosity. Third thing is, do not stop hydroxyurea during febrile episodes unless the counts are low, because we should not interrupt treatment. I give 6 days a week or 5 days a week and give 1 or 2 days break, so less toxicity. And of course, vaccination, penicillin prophylaxis, all is well said and done. Pain is something which we should be very careful about, because a child is really troubled when there is pain. And lastly, I think we don't use red cell cytopheresis as much as should be. You have acute chest syndrome patient comes with breathless, toxic, hypoxic, acidotic maybe. You put him on the machine and you give the machine the command of pre and post transfusion hemoglobin that you desire, pre and post transfusion sickle hemoglobin that you desire, and the child's weight, etc. And the machine does the wonderful job in 3 hours. And by next 6 hours, the child is walking in the ward, not hypoxic, not needing oxygen. So in good hospitals, cytopheresis is possible. If you don't have good cytopheresis instrument nearby, transfer such patient rather than trying to do mechanical exchange, which is very, very hazardous. So these are the 3 or 4 things that we made. And lastly, I think your pediatrician is not very well versed with treating sickle cell disease patient. He can be part of shared care, where higher centers actually manage the long-term management, and the pediatrician manages the acute complication like fever, cough, some diarrhea, something, so that both can do their job rather than trying to pull on and on and on, and then the child become very sick, and then to shift to a tertiary care center at the end, it will jeopardize the life of the child.
I think sir is well taken with regard to shared care. This is a very important message. We should understand our strength and limitations and then act accordingly. That's extremely important. Having said that, I have one query to all experts who are available with us, starting from Dipti Madam to Yadav sir and Nitin Shah sir. What is the optimal HBS level one should target? I mean, there are two. One way is to look after or prevent the sickle crisis, especially the strokes. So, is that policy we are following? Two questions. One is, what is the optimum HBS level with regard to percentage, and are we following that policy?
No, so when you have a sickle cell anemia patient who is on hydroxyurea, you really have no your control over how much HbS you will keep, because it will still be high. But because you are raising HbF to 5, 6%, 8%, it is counteracting on a sickling and preventing the symptom. So that is one thing. But when you are putting the patient on chronic transfusion because of either previous bad chest syndrome or an acute splenic crisis or a patient with stroke, there you can keep the HbS level below 50%. Below 40%. That's the rate, and that's how you prevent any further severe sickling and any further complication. But that's only in patients who are going to be put on chronic transfusion therapy like a thalassaemic child. Otherwise, on hydroxyurea, you go by HbF level rather than HbS level.
S level, that's. And suppose we have a stroke, then is there a regime that we have to keep the for prevention of further stroke to keep the HbS level below particular level?
So before hydroxyurea was available, these children used to be put on chronic transfusion therapy like a thalassaemic child. But now with the advent of hydroxyurea, I think we often don't do it. Especially if the patient is not on hydroxyurea or not on the correct dose, we would try to correct him on hydroxyurea, see whether he has a recurrence. Second stroke is an indication to transplant, until the transplant happens, to put him on chronic transfusion prophylaxis.
Yeah, thank you, sir. So I open the forum for next 5 minutes from the delegate that we have. Then otherwise, if there is no question, we close the session. Already it is 55 past 10.
Yeah, I think we should close now.
Yeah. So, Sanjay Bhau?
Yes, sir.
So, yeah.
Yes, sir. So I'm very thankful to the.
There is some question. Yeah, somebody is asking some question.
Hello?
Yes, madam.
Madam, unmute करा.
सर परमिशन आहे ऑलरेडी.
हो पण मॅडम.
नाही, कोण बोलत होता? कोणी नाही बोलला. I think it was just a background.
Okay. Sanjay Deshmukh, go ahead.
So thank you to all esteemed faculties, our respected Dr. Dipti Jain madam, Dr. Yadav sir, and Dr. Shraddha for throwing the insights on the sickle cell disease management. On behalf of MahaIP, I am thankful to our scientific chairperson Minas sir for giving this opportunity. I also thank Dr. Nitin Shah sir for his immense contribution and presence to today's meeting.
True.
And I hope tomorrow again we will meet on another journey of MahaIP with medical legal cases on this same platform. So good night, and tomorrow I am waiting to welcome you all.
So the tomorrow the topic is the bench, the bedside, changing trends of clinical practice.
Yes.
So basically, the recent judgment that have changed our clinical practice. That is we are going to discuss tomorrow.
Yes.
Okay, thank you all.
Good night.
Bye.